Um, Welcome all to the next session of the ISCCM Journal Club, which focuses on simplifying evidence-based medicine to bedside medicine. So we are glad you're all here. And we have here as our expert, Professor Rakesh Garg. He has joined already. He is the professor in All India Institute of Medical Sciences and specializing in onco anesthesia, critical care, and pain and palliative medicine. He's also the editor-in-chief of Indian Journal of Anesthesia. And we have today as our guides Professor Lalit Singh, Respiratory and Critical Care Medicine from SRMS IMS Bareilly. He's also the organizing secretary of UP Criticon 2026. And I think Dr. Amaja is indisposed. She is not able to join. And we have Dr. Tanmay. I think Dr. Tanmay will be joining, isn't it? He's the additional professor from the Department of Emergency Medicine, SGPGIMS Lucknow, and he's also the ex-chairman of ISCCM Lucknow. So I'll ask my co-coordinator for the club, Dr. Jay Prakash, who is associate professor, Department of Critical Care Medicine, RIMS Ranchi, to do the introductions of the mentors and the presenters and get the floor open for presentation. Over to you, JP.
Yeah, good evening, all of you. So, without delaying, we will start our journal club. So, our first presenter is Dr. Adit Pratap Singh. He is senior resident and doing DNV in critical care medicine in Regency Hospital, Kanpur. And his mentor is Dr. Shikha Sachan. She is basically from Prayagraj, but she is associate director in critical care medicine, Regency Hospital, Kanpur, and well-known figure in UP Critical Care Society. So I would like to uh, give over to you, Dr. Aditya.
Yes, sir. Thank you, sir.
Please share your screen, full screen, and then start.
Wait a minute. So am I audible now?
Yeah, you are audible.
Yes. A very good evening to respected chairpersons, moderators, and esteemed members of the society. I'm Dr. Aditya, the RNB first year critical care resident from Regency Hospital, Kanpur. So today I will be presenting a multi-center observational study titled Association between Red Blood Cell Transfusion and Adverse Clinical Outcome is Independent of Cardiac History, which is an analysis from the Input Study Group published in Critical Care 2025 by Kimun et al. I would also like to acknowledge my mentor, Dr. Shikha Sachan ma'am, who is a senior consultant in critical care medicine, Regency Hospital, for her guidance and support. So this is the original publication from the journal Critical Care, an open access high impact ICU journal. The strength of this paper lies in its real world ICU data, large sample size, and focus on an area where randomized trial data is limited. That is RBC transfusion practices in patients with and without cardiac history. So
make it in full screen, Aditya.
Yes,
sorry. Make it in full screen.
Okay. Yeah. So the red blood cell transfusion is one of the most common interventions in the ICU. Around 25 to 50% of ICU patients receive at least 1 unit of RBC during their stay. Importantly, most transfusions in ICU are given for anemia and not for active bleeding. Over the last 2 decades, major randomized trials such as the TRIC and TRIS trials have clearly supported a restrictive transfusion strategy. As a result, current guidelines recommend a hemoglobin threshold of around 7 gram per dl for most all critically ill patients. However, in real-world practice, patients with underlying cardiac disease are often transfused at higher hemoglobin levels because of concern regarding myocardial ischemia and oxygen delivery. At the same time, evidence supporting a liberal transfusion strategy in cardiac patients remains limited and inconsistent. So the knowledge gap here lies that while restrictive transfusion is well supported in the general ICU population, patients with cardiac diseases are often excluded or underrepresented in major ICU transfusion trials. Most cardiac-focused transfusion studies involve either acute coronary syndromes or post-cardiac surgery patients. We might have heard about the MINT trial also, which they did in the acute myocardial ischemia, where they compared liberal strategies versus compared liberal strategy and restrictive strategy. So, therefore, it remains unclear whether the presence of cardiac history actually modifies the risk associated with RBC transfusion in critically ill patients. So, there's a significant lack of data on the dose-response relationship of RBC transfusion. In other words, whether increasing number of RBC units is associated with progressively worse outcomes. Additionally, most available data does not adequately reflect real-world ICU practice across mixed populations. It is also unclear whether observed adverse outcomes are driven by differences in hemoglobin thresholds, nadir hemoglobin levels, or by the transfusion itself. As a result, transfusion practices for ICU patients ICU patients with cardiac disease show wide variability with no clear evidence-based consensus. So this study had two clear objectives. The primary objective was to assess the association between RBC transfusion and a 28-day composite adverse outcome in critically ill patients. The secondary objective was to specifically evaluate whether this association is also modified by the presence of cardiac history. Cardiac history was defined as a history of prior acute coronary syndrome and heart failure, which mirrors real-world ICU documentation rather than strict trial definitions. So this was a post hoc analysis of the input study. The original input study was an international multi-center prospective observational cohort, which already gives its strong external validity. The data was collected from 233 ICUs across 30 countries and 6 continents, making it highly representative of global ICU practice. The study period extended from March 2019 to October 2022. Patients were followed for up to 28 days during their ICU stay, which aligns with the standard outcome assessment in critical care studies. A total of 3,643 critically ill patients were included in this analysis. Among them, 746 patients, approximately 20%, had a documented cardiac history. The remaining 2,897 patients, or 80%, did not have any recorded cardiac disease. The cardiac history was, again, we have previously discussed it, that it was defined simply and clinically as a prior history of acute coronary syndrome and heart failure. This figure shows the proportion of the patients who actually receive the RBC transfusion. Interestingly, 51% of patients with cardiac history received at least 1 unit of RBC transfusion compared to 49% in patients without cardiac history. This suggests that RBC transfusion was common and fairly similar in both groups, despite the traditional perception that cardiac patients are transfused much more liberally. This also indicates that the transfusion decision in ICU may be more driven by illness severity and anemia rather than cardiac history alone. So coming to the study outcomes, the primary outcome of this study was a 28-day composite outcome. This composite outcome included 3 clinically relevant events: death, new onset acute kidney injury, and ventilatory weaning failures. This rationale for choosing a composite outcome was to capture overall organ dysfunction and ICU relevant morbidity rather than focusing only on mortality. The secondary outcomes included analysis of the individual components of the composite outcome separately. In addition, the authors also evaluated ICU mortality and 28-day mortality as standalone endpoints. So this helps to understand whether any association observed with the composite outcome is driven mainly by mortality or by non-fatal organ dysfunction. So here the exposure of interest is obviously red blood cell transfusion. Transfusion exposure was defined simply as a receipt of at least 1 unit of RBC during the ICU stay. Importantly, the number of RBC units transfused was also recorded and categorized as 0 units, 1 unit, 2 units, and 3 or more units. This allowed the authors to assess the dose-response relationship rather than a simple yes or no effect. They also recorded the nadir hemoglobin, which was the lowest hemoglobin value during the ICU stay, and the declared hemoglobin threshold, meaning the hemoglobin level that triggered transfusion. So a key methodological point is that only transfusion occurring before the outcome event were included, which reduces the risk of severe causality. Overall, the analysis focused on whether increasing the exposure to RBC transfusion was associated with progressively worse outcomes. Now, for statistical analysis, the author used weighted multivariable logistic regression model. These models were adjusted for several clinically relevant confounders, including age, gender, severity of illness, admission diagnosis, mechanical ventilation, vasopressor use, and baseline hemoglobin. This extensive adjustment was done to minimize confounding by indication, which is a major concern in transfusion studies. In addition, an interaction analysis was specifically performed to evaluate whether the effect of RBC transfusion differed based on the presence or absence of cardiac history. And the results were expressed as odds ratio along with 95% confidence intervals. Odds ratio greater than 1 indicated an increased risk of outcome associated with transfusion, while confidence intervals were used to assess statistical precision. A p-value of less than 0.05 was considered statistically significant. This slide summarizes the baseline characteristics of patients with and without cardiac history. As expected, patients with cardiac history were older, had more comorbidities, and had a higher severity of illness at ICU admission. Most of these baseline differences were statistically significant with p-value less than 0.001. Importantly, patients with cardiac history were also more likely to receive RBC transfusions, mechanical ventilation, and vasopressor support. These differences highlight that cardiac patients represent a sicker subgroup, which makes adjustment for confounding absolutely essential when interpreting transfusion outcomes. This slide compares transfusion practices between patients with and without cardiac history. First, transfusion rates were very similar, 25% in cardiac patients versus 24% in non-cardiac patients, although this small difference was statistically significant. Second, the median nadir hemoglobin during ICU stay was slightly higher in cardiac patients, that is 7.6 gram per dl, compared to non-cardiac patients, 7.4 gram per dl. Again, suggesting a tendency toward maintaining higher hemoglobin levels in cardiac patients. Third, the declared hemoglobin thresholds for transfusion were numerically higher in cardiac patients, that is 8.5 gram per dl versus 8.0 gram per dl, but this difference did not reach statistical significance. So overall, these findings suggest that while transfusion behavior trends differ slightly, the actual transfusion rates are remarkably similar between the groups. Now coming to the key findings of the study, RBC transfusion was independently associated with a higher odds of the 28-day composite adverse outcome. Importantly, there was a clear dose-response relationship as the number of RBC units transfused units transfused increased, the odds of adverse outcomes also increased. Each additional unit of RBC transfused was associated with a more than twofold increase in the odds of the composite outcome. So this consistent dose response relationship strongly supports a biological plausible association rather than a random finding. This forest plot shows the result of the weighted logistic regression analysis. The odds of the 28-day composite outcome increase with each additional RBC unit transfused, both in patients with cardiac history and without cardiac history. In simple terms, RBC transfusion was harmful to a similar extent, irrespective of whether the patient had underlying cardiac disease or not. So the presence of cardiac disease does not appear to protect against transfusion-associated harm. Now, this slide directly addresses the central clinical question of the study. The authors performed a formal interaction analysis between cardiac history and RBC transfusion exposure. The results showed no statistically significant interaction, meaning that the effect of RBC transfusion on adverse outcomes was similar in patients with and without cardiac history. As shown in the graph, increasing number of RBC units was associated with progressively higher odds of adverse outcomes in both groups, and the interaction p-value was not significant. That is, p-value was around 0.44. In simple terms, cardiac history does not appear to attenuate or amplify transfusion-related risk. In the secondary outcome, the RBC transfusion was associated with significantly higher odds of acute kidney injury and ventilatory weaning failure. These associations were statistically significant with p-value less than 0.05. Mortality showed a consistent trend and towards higher risk in transfused patients, but this was not uniformly statistically significant across analysis. So this suggests that transfusion-related harm may manifest more clearly as organ dysfunction and prolonged ICU course rather than mortality alone. So the strength of the study, this study has several important strengths. First, it is a large international multi-center ICU cohort, which improves generalizability across different healthcare settings. Second, it reflects real-world transfusion practices rather than protocol-driven trial conditions. Third is data collection in the original input study was prospective, reducing recall and documentation bias. The analysis adjusted for multiple clinically relevant confounders, included a dose response assessment, and performed a formal interaction analysis for cardiac history. So together, these features make the findings robust and clinically meaningful, despite the observational design. There are, however, important limitations. First, as an observational study, causality cannot be established. Second, there is a potential for residual confounding, particularly confounding by indication, since sicker patients are more likely to receive transfusions. The study did not capture exact transfusion triggers or specific indications, such as ischemia versus anemia alone. Additionally, the composite outcome include components of varying clinical importance, which may not carry equal weight. Finally, because outcomes were relatively common, odds ratio may overestimate the relative risk. So these limitations should be kept in mind when interpreting the results.
Aditya, hello.
I think something has happened with this connection.
Okay, anyway, he already presented all
Yeah.
things. The take-home message we can see easily here.
Aditya,
You just switch off your screen only. Video, switch off your video. Okay, anyway.
I think we've lost connection with him.
Okay, he already presented that
Yeah.
one. So the what we actually got by the take home message was uh, yeah, Aditya, can you hear me? Anyway, so this is a very good study, and already he said about this is very large prospective ICU cohort international study, and the good thing is that the clinically relevant composite outcome and which captures both mortality and organ dysfunction. Although yes, few limitations were there, but if you look at the clinical interpretation, so this study mainly reinforces the RBC transfusion in the ICU that is not benign, and it appears incrementally harmful even at low unit numbers. So what exactly Lalit sir is there?
Yes, he's
Yeah,
there.
sir is there.
uh, okay,
Yes,
Kalamati ma'am.
Yeah.
Yeah, welcome Lalit sir.
good evening, JP. And
Yeah,
I congratulate Dr. Sika and Aditya, mentor and presenter, the well prepared topic,
Thank you, sir.
an
yeah.
important topic.
So Lalit sir is very famous person in the uh, ISCCM chapter. National is a national figure. Sir is professor and head of respiratory and critical care medicine SRMS Bareilly, and he organizes many conferences. So first, I would like to ask to Lalit sir regarding that. What you are expecting that? So hello. If you, because this input trial mainly based on the whether patient having cardiac or non-cardiac patients. So given that many cardiac patients were transfused above guideline thresholds, so what factors you are feeling that most commonly drove transfusion decision, and physiological triggers or clinical preference? Lalit sir, over to you.
Uh, uh, yes, Dr. JP. Uh, it's a very interesting topic, and it's a topic of debate. In fact, we understand in ISCCM or in our day-to-day clinical practice, transfusion decision in cardiac patient appear to be driven more by clinician preference or precautionary judgment rather than the objective physiological trigger. And what I understand, it should be individualized practice rather than the protocolized transfusion decision. And the second thing is that this topic needs a large randomized control trial, what I understand, because you also observe that in our day-to-day practice in primary consultant used to take round in ICU. If they think this patient has a chronic heart failure and some cardiac issue, they just transfuse the blood transfusion. It should not be. It should be in individual practice, and it's my take home. And I need some expert comment from the if Rakesh is there.
Dr. Rakesh is
Dr.
there. Yes.
Rakesh is there.
Yeah.
Rakesh sir
Rakesh sir.
message in chat box that network issue is there.
Okay.
So okay,
Dr.
so
Kalavati, your take.
okay, so we have seen that most of the in this study cardiac patients were transfused at higher hemoglobin threshold. And if you look at the
Yes.
documented equation and physiological trigger, that were similar to those with the cardiac history, which suggests that it's a tendency towards the risk aversion and fear of anemia, which is related to the ischemia rather than the clear evidence of the oxygen delivery failure. Now, one question I would like to ask from mentor of Dr. Aditya to Dr. Sikha, I would like to ask how would you integrate physiological mark of oxygen delivery like lactate, SCVO2, echocardiography into this transfusion decision making for this those kind of cardiac patients?
I think with so many trials that have come post the trick trial, which have actually shown that the non-inferiority of restrictive transfusions strategy over liberal transfusion strategy. And when we talk about hemoglobin, about blood transfusion, the main goal of trying to transfuse a patient is because you want to optimize the oxygen delivery to the tissues. So whether it is a cardiac patient or a non-cardiac patient, the goals remains the same. You have to assess through certain parameters as well as clinically whether your DO2 to the patient is optimized. And we know that when it comes to decreased oxygen delivery, not just hemoglobin but cardiac output as well as SaO2, all are important parameters. So yes, if you feel that the lactate clearance is not improving with your standard therapy and your cardiac output is too much compromised, and clinically also, of course, you can measure the SCVO2 or central venous or mixed venous oxygen saturation, but beyond that, even standard capillary refill time, if it is prolonged 4 or more than 4, then all these parameters can actually give some hint that your DO2 may be compromised, and then this patient may require blood transfusion. Just chasing a target is not going to help, even though many trials have shown that both strategies are non inferior. But we know that even a single blood transfusion can have various other serious effects, which some of them which can actually be very long term and may not be foreseen today but may be cause an impact later on, such as immunomodulatory effects or effects of sepsis. So optimizing delivery of oxygen to the
So
tissue
is there any
is
role of
most important.
is there any role of echocardiographical evidence?
Yes, of course, looking at the cardiac output and the stroke volume, if there is a compromised stroke volume and cardiac output, then along with decreased lactate clearance, then you can think that perhaps the cardiogenic shock is there, and because you cannot improve the cardiac output in a cardiac patient to a certain limit, then you must increase the hemoglobin so as to optimize the delivery.
Yeah.
Yeah, so
Based on
if transfusion improves oxygen, she explained very well. If transfusion improves oxygen delivery, why are the outcomes getting worsened? Because we expect that there is idea, and we can see that there is a liberal strategy which has been followed, and sure enough, the outcomes were showing a negative impact. But the idea is that transfusion improves oxygen delivery. So, can we deliberate little bit on why the outcomes have been poor? Like, actually, she explained a little
Because
bit. Yeah,
there are a lot of risks associated, because most of these studies have also assessed the rate of complications, and few causes, and the complications or the negative impact has always been assessed in terms of mortality.
yeah,
So, when it comes to mortality, the reasons for increased mortality in patients who received more transfusions was related to usual complications like post transfusion sepsis and fluid overload and other such factors. So, the no more need of more studies need to be done to just focus on the complications associated with blood transfusions, because most of these studies have focused only on absolute numbers of 28 days
yeah.
mortality. So we need more studies to focus on as to why the risk of mortality increases with the increased number of transfusions. That needs to be assessed.
Also,
okay,
the question of the whether microcirculatory flow,
Yeah.
and as you said, the lactate clearance, everything has to be taken into account. And oxygen delivery, we are making sure, but again, oxygen utilization is not again taken into account.
yeah, in chat box, I am getting one question that in a septic patient, if SCVO2 is low, should we target a higher hemoglobin? No, not necessarily, because in a septic patient with low SCVO2, the priority is to identify and correct the exact cause of impaired oxygen delivery,
Yes,
not to relatively target a higher hemoglobin. Because most of the time, if you will see in sepsis, if you low SCVO2, it is most commonly reflects the low cardiac output. You say hypovolemia, increased oxygen consumption, or just now you said, ma'am, microcirculatory dysfunction. So raising hemoglobin may be considered only if anemia is very severe, more less than 7 gram per dl, or selected in case of very high risk cardiac patient. Hello. Okay. So I feel that we completed our first presentation. So over to you, Kalamwati ma'am.
Yeah, we now have our second presentation, the OPT-PRESS trial. The presentation will be by Dr. Tilak Raj, DRNB trainee from Apollo Hospitals, Greaves Road, and the
Ma'am,
mentor.
Ma'am, one in chat box, I'm seeing
Yeah.
one question. Is there any way to calculate oxygen extraction ratio and its role in clinical practices? Yes, oxygen extraction ratio you can calculate. There is some formula that SaO2 minus SvO2 upon SaO2. This is given in many ICU book, especially in cases of shock and sepsis patient. Okay, over to you, ma'am.
Yeah. So the presenter is Dr. Tilak Raj, the DRNB trainee from Apollo Hospitals, Chennai. And we have as our mentor, Dr. Vignesh, consultant critical care from Kamakshi Memorial Hospital, again, Chennai. So over to you, Dr. Tilak. You can go ahead with the presentation.
Good evening to one and all present over here. Am I audible, ma'am?
Yes.
So I thank ISCCM faculties for giving me this opportunity to present this trial, and I also thank my moderator for today, Dr. Vignesh. So moving on to the study. So the topic of discussion today is going to be OPT-PRESS trial. It is a multi-center open-label RCT which we are going to discuss today, which basically is efficacy of targeting high mean arterial pressure for older patients with septic shock. So the background of the study is sepsis, which is a leading cause of death worldwide. The mortality ranging between 38 to 52%. According to the surviving sepsis campaign guidelines, which recommend a MAP of 65 mmHg, mercury, the optimum BP target in septic shock remains debatable. There are previous studies which have looked at it, which have been looking at it, and this is one of the study to support it. So surviving sepsis guidelines clearly recommends a MAP target of 65. A study, sepsis PAM trial, which was done to comparing a high mean arterial pressure with a low mean arterial pressure in patients who are aged more than 65 years. And they found there was no significant difference in the 28-day and the 90-day mortality. But there was a subgroup analysis which showed that in patients with higher MAP target group had a reduced incidence of renal replacement therapy. So there are many systemic analysis reviews and meta-analysis which also looked at this, but they didn't find any difference in mortality. There was a study which is called 65 trial which looked at permissive hypotension targeting a MAP of 60 to 65 was a standard care in patients aged more than 65 years of age, and they also did not find any difference in mortality.
Sorry to interrupt, Dr. Tilak. Your slides are not changing.
Shall I start over, sir? Or
Yes,
Start over. Start over.
Yes.
So the background of the study is sepsis is the leading cause of death worldwide, and the mortality of septic shock is around 38 to 52% across the countries. The surviving sepsis guidelines recommend a MAP of 65 mm of mercury. So the optimum blood pressure in septic shock remains debatable. There are many studies previously looked at it. So starting with the surviving sepsis guidelines, which aimed at a target MAP of 65. And there was a trial published, sepsis PAN trial, which looked at higher BP and a lower BP MAP target in elderly patients with septic shock. They found no significant difference in 28-day and 90-day mortality, but there was a subgroup analysis which showed in higher MAP group there was reduced incidence of renal replacement therapy. And there are various systemic reviews and meta-analysis that were published in 2023, which also looked at the same, but they didn't find any mortality difference. And there was a study 65 trial which specifically looked at permissive hypotension in elderly patients, targeting a MAP of 60 to 65 as a standard care, and they did not find any mortality difference. So Why do we actually need a higher MAP target in elderly hypertensive individual? Possibly thinking that an altered auto-regulation is possible, requiring a higher MAP target. So the prevalence of chronic hypertension is around 66.9%. So by targeting a higher MAP in elderly patient, we are looking whether the clinical outcomes will improve. We also in this protocol, they looked at to reduce the to minimize the catecholamine related adverse effects. The concomitant use of vasopressin early was also looked at. So moving on to the methodology. What was the study design? It was a multi-center study, obviously, conducted in 29 ICUs in Japan. It was also a pragmatic study, an open label and randomized control trial. Now looking at the PICO, the population we are dealing with were elderly patients aged more than 65 with septic shock. The intervention was to maintain vasopressors to keep a higher MAP of 80 to 85 compared with standard treatment, maintaining a MAP of 65 to 70. The primary outcome was all-cause mortality at 90 days, and the timing was from July 1st, 2021 to December 2023. So it was relevant in terms of PICO. So what is a pragmatic trial? Pragmatic trial is nothing but when intervention works in a real world settings. It is used in a routine clinical practice. It is almost flexible. The control group is usually the standard practice, and blinding is usually an open label study, and generalizability is usually high. The external validity is high. The internal validity is moderate. So what is the inclusion criteria? The study looked at patients more than 65 years of age and patients with septic shock as defined by sepsis 3.0 admitted to intensive care unit. The exclusion criteria were all the patients who had high probability of transfer to another hospital, patients who were on vasopressors for more than 3 hours, who experienced a cardiac arrest, who were diagnosed with COVID-19, who had a DNR status, or any medical condition where these strict MAP targets could not be maintained, and other patients obviously when they were not able to provide consent. So randomization was basically done using a centralized computer generated allocation sequence. They were randomly assigned to two groups, a high target group and a control group in 1:1 ratio. Here stratified block randomization was used, which is blocks of 10 were used, and they were basically divided into people with hypertension and without hypertension, age less than 80 and more than 80. As said earlier, it is an open label trial where the treating physician was blinded and statistician was masked to group allocation. Was not blinded and statistician was masked to the group allocation. So the intervention was the target MAP, which was 80 to 85 or 65 to 70, was maintained for 72 hours after randomization or until the vasopressors were no longer needed. And after 72 hours, it's left to the clinician's discretion to maintain the MAP. The BP monitoring here, they've done non-invasively either in the left arm or the right arm. If NIBP was not possible, they used invasive arterial pressure monitoring. Radial was preferred, then femoral, then brachial. So they followed certain safety measures. Like when in a high MAP group, whenever there was a significant bleeding, MI, ischemia, intestinal ischemia, arrhythmia, or limb ischemia, they moved back to 65, MAP of 65. To minimize the adverse effects of catecholamines, whenever the noradrenaline dose increased more than 0.1 mics per kg per minute, vasopressin was initiated, and physicians were required to follow the latest surviving sepsis guidelines for sepsis management. The fluids, steroids, and organ supports were all determined by the physician. If the targets were unmet, the physician could introduce another vasopressor, increase norepinephrine, or introduce dobutamine or hydrocortisone. So the outcomes that were looked up were the primary outcome was obviously the all-cause mortality at 90 days after randomization. The secondary outcomes were all-cause mortality at 28 days, sepsis-related mortality at 28 days, and all-cause mortality at 90 days. Metabolically, they looked at lactate clearance at 24 hours, organ support free days at 28 days were like ventilatory free days, renal replacement therapy, catecholamine free days were all looked at. The safety outcomes, because they initiated vasopressin early. They looked at the incidence of arrhythmia, thromboembolism, and hemorrhagic events. For functional outcomes, they looked at clinical frailty score at 90 days. So the statistical analysis, incidence of the primary endpoint, the control group was kept at 45% with an absolute difference of 10%, an alpha error of 0.05 with a power of 80%. The sample size with a dropout of 10% was set at 836 patients. Coming to the analysis, the primary analysis, both the primary outcome and the secondary outcome was based on intention to treat analysis. Fisher's exact t-test and rank sum test was used. In case of secondary analysis, the primary outcome was based on per protocol analysis. The secondary outcome was based on sensitivity and survival analysis. Subgroup analysis that looked at age and hypertension. There was also an interim analysis which was done. So moving on to the interim analysis, there was a safety monitoring committee which recommended an early termination of trial. So the totally 561 patients were screened. Due to the concern of harm, the study was stopped earlier. So this is the concept. So initially they started with 561 patients. After excluding 518 patients underwent randomization. They were randomized in 258 and 260 patients. One in each group were excluded due to inappropriate registration. So following that, in secondary analysis, per protocol analysis was done, and 242 in high map group and 246 in control group were used. So this is the table 1 comparing the baseline characteristics. The age were comparable in both the groups, and the most important comorbidity which we are looking at was chronic hypertension, and the source of infection was abdomen followed by urinary tract followed by lung. The mean lactate levels, PF ratio, and the SOFA score were comparable in both the groups. Even the Apache score was comparable. So looking at the median amount of fluid, both the group received were almost equal, but the vasopressors, the non-heparin vasopressin requirement was high in the high target group. So they used the Bosc and Whisker plot for the analysis to find the skewness in data. This is the Bosc and Whisker plot which looks at map in both the groups. To understand this, so what this basically means that in patients with high map group, control group, it took only 4 hours for the patients to reach the target map, whereas it took around 8 to 12 hours for people in high target group to reach the median target. And also, as you can see, the number of patients on the vasopressors at 72 hours were only 63 in the control group. It was 103 in this one group. This plot basically shows that the map was well separated throughout the observation, and it was sustained over time, and the outcomes were credible. Moving on to the primary analysis. The primary analysis, as said earlier, was based on intention to treat analysis, and there was a huge difference. High map group had mortality of 39.3%, whereas the control group had only 28.6%, and the p-value was significant. So moving on to the secondary outcomes, all the mortality outcomes were clinically significant. The renal replacement therapy, the ventilator-free days, and the catecholamine-free days were better in control group, and they are more in high target group. And all the early metabolic lactate clearance and the frailty score, there was no significant difference between the two groups. And the safety outcomes observed between the two groups also did not show any difference, and they were not significant statistically. Moving on to the secondary analysis, where per protocol analysis were used. Same findings as the primary analysis were confirmed. The all-cause mortality and all the mortality at 28 days and sepsis-related mortality were significant. And the renal replacement therapy, ventilator-free days, and catecholamine-free days, as said earlier, were also significant. And the lactate clearance and the CFS was not that significant. And the major kidney, the make were higher in high target group, but was not statistically significant. They used the Kaplan-Meier curve for the secondary analysis, secondary outcomes. This Kaplan-Meier curve basically is the probability of survival over time. It accounts for the sensor data, the participants who leave the study early or haven't experienced the event by the end of study. X-axis, we have the time, y-axis is the survival probability, and the curve, if it drops, it shows the death rate. As you can see clearly, the control group and high target group are clearly separated from each other. After the randomization, by 98 days, they obviously separated a lot. A log rank test was run comparing the curves, and it was significant, 0.007. The hazard ratio of 1.47, which states that there was 47% chance of death in high target group at any point in the curve when compared with the control group. As you can see in the bottom of the screen, the number of persons at risk at 90 days were only 186 in control group and 156 in the high target group, which is quite a difference. And then they perform sensitivity analysis. These tests test how robust your trial conclusions are to the changes in assumption. That is, when you change the input variables, how your results are affected. So they looked at median. So median renal replacement therapy, ventilator free days, and catecholamine free days, all were statistically significant. The lactate clearance and the frailty score was not significant. And they also looked at all-cause mortality at 90 days, the all-cause mortality at 20 days, mortality from sepsis at 90 and 20 days. All these were significant. And the lactate clearance, the frailty score, these were not significant. As compared to the primary outcome, the renal replacement therapy, the ventilator-free days, and catecholamine-free days were significant. So they also looked at clinical outcomes in hypertensive subgroup. They looked at people with hypertension and without hypertension. And they found that the all-cause mortality at 90 days was higher in people without hypertension, but adding hypertension did not change the analysis. But the p-value of interaction was not significant in this observation. All the secondary outcomes were also had similar results. So concluding it, higher MAP target in elderly septic shock patient increased mortality and worsened organ support outcomes. That is renal replacement, ventilator free days, and catecholamine free days. So standard MAP target of 65 to 70 remains safer. Early vasopressin use did not mitigate harm. So strengths of the study, obviously it was a multi-center study which was generalizable. Pragmatic real-world conditions were used. It is an RCT where stratified block randomization was used with moderate internal validity. Intention to treat was preserved. It was the first large elderly focused septic shock RCT. And there was also an interim analysis which led to the early stoppage of RCT, ensuring patient safety. There was a specific protocol for vasopressin administration, and the statistician here was masked. What are the limitations? Obviously, it was an open label study where the investigator were not blinded, only the statistician blinded. They used non-invasive BP monitoring for observing. It is a multi-center study in Japan, a single ethnic group. Generalizability is questionable, and clinical management was left at physician discretion. Variability in care has been observed. And regarding the hypertension status, there was also always a chances of misinformation. There was a pre-estimated mortality based on Western studies, which were more than the actual observed mortality in the control group. So the take-home message is, in elderly septic patient, more is always not better. So sticking to a MAP target of 65 to 70 is obviously being recommended still now. Thank you.
Thank you, Dr. Tilak, for the wonderful presentation. So I would like to add on some points actually to the study. One, yeah, it's a very well pragmatic study which is well conducted. Tilak, would you mind going to the viscous plot which you are showing before?
Yeah, Dr. Vignesh, you want to say something?
Yes. So,
Hmm.
so when you look at it, this plot in the control group, the people who was becoming or vasopressor free people has got increased much faster. And you look at the BP targets, even in the control groups, are actually become much higher later to 40 plus hours of randomization, meaning that the usage or less usage of norepinephrine actually they got better faster and the map targets become their own baseline. So this is something which is significant, and the discussion quite happened during this point was whether the norepinephrine has, as proposed before with some studies, have immunosuppressive action, which is causing or which is preventing the people from faster recovery. So that is one point which has been put forth in the discussion regarding it comes to this part. So this is something which is key.
Yes, exactly. So, yeah. So based on this study, what exactly we can interpret that after aggressively targeting higher MAP in especially in elderly septic shock patient, it may appears harmful. That is likely may be due to excess vasopressor exposure, and the main challenge is what I felt that the concept of routinely, especially individualizing map to just lift for the chronic hypertension. So, uh, if you will go through the current guideline recommendation, which is generally saying that to avoid unnecessary vasopressor escalation beyond map if it is more than or equal to 65 millimeter of mercury in most of the patient.
That brings to the question again, are we chasing the right target? Is MAP the right target to chase? Because there is increasingly more and more revelation that pressure is not equivalent to flow, and then thereon. And in sepsis, we have a cascade of effects, and the microcirculatory failure is finally the one which is clinching the benefit or no benefit. So, is MAP the right thing to chase, or should we be looking at something else? And the other problem with chasing the MAP is that we'll be chasing only one target without making sure that it translates into flow and better perfusion. And
Yeah.
that leading to more damage because of the vasopressor. Uh,
Yeah, ma'am, if in
Yes.
2014, there was one study, sepsis PAM trial. So based on same high versus low blood pressure target in patient with a sepsis patient. So if you will go through that, so I would like to one question from our guide, Lalit sir is there?
yes, Lalit sir is there. Sir, your
Okay.
Yes,
opinion?
yes.
Yeah.
Yeah. So, sir, I would like to ask, especially based on this OPACE trial and sepsis PAM trial, how does it differ from together? One thing is that in view of the renal benefit, and if you, what exactly you are feeling that why did chronic hypertension not modify the outcomes? Lalit, sir, over to you.
Okay, it's very interesting and very good question for especially for uh, DNB and IDCCM students. In sepsis palm suggest less RRT with higher MAP, mainly in hypertensive patient, right?
Yes, sir.
But this was a
Yes.
secondary signal in a younger, less frail population was studied in that trial. In Optress enrolled elderly patient only and higher frailty in that group with CKD burden, and so the greater cumulative vasopressor exposure in the high MAP arm.
Yeah, exactly.
Yes.
In this context, we can say a theoretical renal perfusion benefit was offset by vasopressor toxicity,
Yeah.
leading
Exactly, sir.
to fewer renal replacement 3 days and higher mortality with no renal benefit, what I understand. And second part of the question, Dr. Jaiprakash rightly asked, why did chronic hypertension not modify outcome? In my views, in septic shock, especially in the elderly, autoregulation is impaired and microcirculatory dysfunction dominates. So
Yeah.
higher MAP does not improve organ perfusion.
Yes.
And hypertensive status may be misclassified in the emergencies. And vascular stiffness, fertility, increased susceptibility to vasopressin harm. And consequently, higher MAP provide no benefit even in hypertensive patient. And challenging the rationale to pressure-based escalation. This is my take home this for this two different trials.
Yeah, exactly, sir. So, in chat box, I'm getting one question that is there any subgroup analysis? Already secondary analysis they did for the based on the their in this OPPRESS trial, they did subgroup analysis, not subgroup secondary analysis they did, and sensitivity analysis of the secondary outcome they also did as per the protocol. So they already mentioned that. So Kalavati ma'am,
Yeah.
Rakesh sir is there or not? Rakesh
Sir
Garg
is there. Yes. One second. Sir is there. Rakesh, yes. Sir, Rakesh sir.
There is a some, I think, Dr. Rakesh
his network problem. He
had
already
some
messaged. He's
net issues.
traveling. Yeah, he's traveling now. Yeah.
Okay.
Yeah.
There is another question. Is there any adverse effect profile in higher MAP group?
Yeah, on comparison, they didn't find an adverse effect profile which is pertinent only to the higher MAP group. I think that's because the study was not completely done. So maybe if the study was completely done, maybe you could have found a significant difference in terms of adverse events in the higher MAP group. But I think the study was stopped for in terms of patient safety.
Yeah. Trial was stopped early for harm, and that's
Yes.
why because the primary outcome was the mortality at 28 days and 90 days. So at 90 days, the mortality was significantly higher, especially in higher MAP group. If you will look at the risk difference, it was around 10.5 or 11, something that. So higher MAP was associated with fewer organ support free days and more adverse event. That's why they in between they stopped the trial. And Lalit sir already pointed very well about the chronic hypertension and the differences between the OPTIPRESS and sepsis pram trial. So, Kalavati ma'am, over to you.
Yeah. So I have a question. Does early trial termination exaggerate harm? The study.
No. I don't think so. It exaggerates some. They have done even the sensitivity analysis as well for all the confounding elements actually, and it shows that it's a definite harm which has been shown in this trial.
There has been a very definite trajectory in that. So that confounder is taken off. And another question is the harm due to MAP or due to vasopressor burden?
It is hard to differentiate actually, but I would say it is because of the both. Yeah, they didn't find a definite evidence of the vasopressor burden causing the harm, but I would say it is both.
Yeah. And moreover here, I think the elements of cardiac afterload, then the possibility vasopressor toxicity, all those also come in, which were exaggerating the harm effect. And ethically also, I think it is clinically plausible that they stopped the study in between. Any question? Let me just.
Question in chat box, ma'am?
Yeah. Any data with viral sepsis versus bacterial?
So based, so this is epidemiology study, but what I read earlier that if you go through the epidemiology, so viral sepsis is increasingly recognized, especially influenza, dengue, COVID last, we have seen lot of cases there. But if you look at the overall things, the bacterial sepsis is still predominant in the ICU. And viral sepsis, if you will see that, is still underdiagnosed because cultures are negative and we are not doing viral PCR routinely.
So again, there comes the question, would we be missing a responder phenotype? There might be a group which might benefit. Are we missing that? Dr. Vignesh, you have any on that?
I'm not sure about that. The responder phenotype, we don't have a specific defined data to classify them as a responder phenotype at this point with the given data. So I'm not sure about that.
Okay, but I think the movement is more towards the dynamic perfusion markers like lactate clearance, capillary refill, and renal Doppler, microcirculation. So maybe, maybe not. But then again, I think we need to more take into account dynamic perfusion markers and individualize it. Everything is towards more of personalization. So probably that. Sir Lalit sir, you have any thoughts? Lalit sir is there?
Lalit sir?
And yeah, there is another interesting question. Does genetics have a role in this result? Because 98% are of Japanese ethnicity. So generalizability is the query here.
Generalizability is the question. And Japanese people are actually, like, as I mentioned earlier, like 67% of the population were predominantly hypertensive. That's why they took up the hypertensive population alone in the study, and it was
Very
studied
interesting
actually.
question someone asked. If you look at the age of the Japanese people, their mean age is quite higher than our Indian population. So yes, genetics may contribute, but it is unlikely in cases of this if you look at the press results, so it is unlikely to be the primary driver. Because if you go in that, because 98% are where Japanese, and it's a genetic influence. Yes, it may contribute because genetic polymorphism affecting the what you say adrenergic receptor, vasopressin receptor, RAS, all these things. So it can influence the vasopressor sensitivity. Am I right, Kalavati ma'am?
Yes, yes. See, that brings to the question whether age alone should be a factor to be considered. And because we now find a lesser age group also having these comorbidities, whether we need to take into account the cardiac dysfunction aspect and the frailty aspect, and not just the age alone.
Yeah, but based on this opt-press trial, if you'll go through that, the genetics may modulate the vasopressor response. But if you will see the current evidence that is based on this trial, these are mainly physiology and exposure driven, not ethnicity specific.
Lalit sir, your thoughts on this? Whether ethnicity?
It's what Jayaprakash is saying. He's rightly pointed out that point.
So, any further?
Okay, so ma'am, so yeah, so so shall we wind up? Yeah.
So actually, both are interesting studies which reinforce the upcoming theories that it's not about a liberal transfusion and to go more and more for conservative approach towards transfusion. And again, MAP target, the sepsis surveying sepsis campaign recommends 60 to 65. So again, this trial again reinforces that point. And it's more and more of individualized and personalized approach to these factors in our daily clinical practice. Sir, if you have any closing remarks, Lalit sir, then we can wind up.
Yeah.
Lalit sir, you have any closing?
No, both mentor and both presenter presented very well, and interestingly, this study is eye-opening for all the newcomers. Yes.
Yeah.
I
you,
appreciate both mentor and presenter for this presenting the nice study, and I appreciate and congratulate to all the, especially Dr. Jayaprakash and ma'am. You are also giving a very important input for the, and thanks to Dr. Vignesh and Dr. Sikha also for giving a input, very interesting input. Thank you.
Thank you.
Yeah. Thank you, Dr. Vignesh and Dr. Shikha, and thank you both the presenters. You've done a wonderful job, and thank you for the resource people, Rakesh sir and Lalit sir, and yeah. So if there are no further questions, we can wind up this session of Journal Club. I thank everybody, and good night to you all.
Thank you all, and good night, everyone. Thank you.
Thank you.
Thank you.
Thank you. Good night.
Thank you, sir.